Hi, I'm Dan Vanatta, and this is my final project for Biomedical Informatics 224, where I'm going to be talking about the drug Metoprolol and its interaction with cytochrome P450. Metoprolol is used in treatment of several cardiovascular diseases, including hypertension, acute myocardial infarction, angina, and others. It works by decreasing the heart rate, contractility, and cardiac output, therefore decreasing the blood pressure. There are many possible adverse events. In the cardiovascular system, there's shortness of breath, arterial insufficiency, palpitations, congestive heart failure, and others. Effects in the central nervous system include tiredness, dizziness, depression, mental confusion, headache, nightmares, and insomnia. Effects in other systems include nausea, dry mouth, gastric pain, etc. The way metoprolol works is by competing with adrenergic neurotransmitters for binding at the beta receptors in the heart. So a blockade at the beta receptor results in a decrease in heart rate, cardiac output, and blood pressure. As you can see in the simplified pathway in the air cell, we have the beta blockers come in and they inhibit action at this first step, which prevents the rest of the pathway from occurring. Cytochrome P450 2D6 is involved in the metabolism of xenobiotics, or substances that aren't normally found in the body. It is also a bioactivator for many substances. In this case, CYP2D6 is the metabolizer of metoprolol. So it gets broken down in the liver, where it undergoes hydroxylation and demethylation before leaving the body. There are 4 different phenotypes of CYP2D6. So you could be a poor metabolizer. There's little or no CYP2D6 function. Intermediate metabolizers have some function, but not as much as normal. Extensive metabolizers is another way of saying normal CYP2D6 function. And finally, there's ultra-rapid metabolizers, where subjects have multiple copies of CYP2D6 expressed, and thus more function than in extensive metabolizers. The prevalence of poor metabolizers does correlate somewhat to ethnicity, where there's approximately 2% Asians that are poor metabolizers, 6 through 10% in white populations, and even slightly higher for black populations. Whereas the occurrence of ultra-rapid metabolizers is greatest among Middle Eastern and North African populations. The genetic basis for this variability is accounted for by the differences in allele frequency among the population. So approximately 10% of whites tend to have the completely non-functional 4 variant, whereas about 50% of Asians have this 10 variant, which results in decreased activity, but still some activity. So it would be intermediate metabolizers. This drug has a lot of pharmacogenomic potential, as there is very strong evidence that the genetic variation leads to drug response in several studies. For example, in a study by Rao, it was shown that the metoprolol plasma concentrations were 6.2-fold higher in patients with inactive genotypes compared to those with two fully functional alleles. And that study had a p-value of 0.0001, which is very strong evidence. Another study found that patients homozygous for arginine at codon 389 had a nearly 3-fold reduction in daytime blood pressure, which had a p-value of 0.0018, which is also fairly strong. So if one has the genotype data, this allows for some clinical utility in that a physician could recommend an alternative drug or dose reduction for poor or intermediate metabolizers, or for ultra metabolizers, one could consider dose titration to ensure that the metoprolol stays at an effective level. My main source for this project was PharmGKB, as well as several papers that I found there. Thanks for listening.